I'm sorry to disappoint you, but there'll be no TB in GeneXpert discussions. When I first came to live in Papua New Guinea more than a decade ago, I would often hear the phrase chanted at me, "It's against our culture." On one occasion, I raised the issue of same-sex practices between men, and a young new graduate student in my training program raged with anger at me, stating that such practices were against PNG culture. The irony for me was that I later found her in the library reading a book of divine Christian healing. I also wondered how a country that sells itself on its cultural and linguistic diversity could have a singular PNG culture. For God's sake, we fight about who cooks the best moo-moo. Seeing her sitting with such a book, the thought came to me, it's not just against PNG culture. Christianity had only been imported some couple of hundred years ago to the country, and primarily to the lowlands and the coastal regions. Only recently, my husband's village celebrated 50 years of Christianity, so it's not that Christianity is a long-term tradition of the country. I will come back to this idea of culture a little later, as I think it's where our opportunities to respond positively and expand our response to sexual and reproductive health lies. But don't be misled, I don't have the answers, I only have experiences to share. PNG is the largest of all Pacific Island countries and has some of the poorest and worst sexual and reproductive health outcomes, both regionally and globally. Yet I don't want to stand here and repeat those. I want to take the opportunity to talk about two areas where I think we can expand and recognise sexual and reproductive rights and justice in separate yet interrelated ways. And for me, this is the family and in healthcare practices. The statistics and prevalence offered by epidemiologists and statisticians are not only concerning, but at times deeply troubling. PNG is always off the scale. But in and of themselves, these prevalence rates, statistics, the confidence intervals and the adjusted odds ratios that often go with them fail to go further, deeper into the culture to understand, address and transform the cultural practices and social structures that these rates and prevalences are a byproduct of. Moreover, in Papua New Guinea, young girls and women find themselves pregnant at school and are forced to leave, whether it be at primary school, high school or at university. If they're not forced to leave legally, they are at least socially. While theoretically legal abortion can be attained under certain conditions, you require at least 2 obstetricians. And these have to be obstetricians who both sign it off. In the provincial hospitals, most provinces don't even have one gynaecologist or obstetrician. Only recently can women consent to a tubal ligation without the approval of a male relative. I'm yet to see a tubal ligation done without a male relative approval. Sodomy and unnatural acts between men are illegal, as is living off the earnings of sex. It's only in the most recent Lookout in Piccaninny Act that child marriage has been outlawed, at least theoretically. Rape in marriage was only recognised some 10 years ago. And yet, ironically, and probably most important in the context of this audience, and in the light of the bleak image I've already presented so far, PNG has some of the most progressive HIV laws, not only in the Pacific, but the wider Asia region. People living with HIV are protected by law from discrimination. They receive free antiretroviral and are supported to have families of their own. And for the youth of yesterday, please note that children from the age of 12 in my country can go to a clinic and be tested for HIV without parental consent. This to me is something many countries could only dream of. This to me is essential if we're going to address the global issue of young people and HIV and increase access to sexual and reproductive help for them and others that follow behind them. As society's norms and practices can constrain as well as facilitate access to sexual and reproductive health, these norms and practices are not static. They are formed and transformed time and time again, sometimes with opposition, while at other times they go unnoticed. I know I'm standing here preaching to the converted, but cultural values influence all aspects of sexual and reproductive health and rights, from quality and access to health education and services, to gendered roles and responsibility, as well as to the laws that govern practice and inform public opinion. Culture is too often applied and used and described as if it's monolithic, immovable and non-transformable. The notion, or at least the claim to a singular culture in PNG, is often used to keep people at bay, particularly those without power, under the control of others. And it's used in a way to resist change, to reject and oppose different ways of thinking and being. It becomes an excuse for why things stay the same. But there are changes, and families are indeed changing. Families are changing their values and their opinions. Let us look briefly at the story of Parker and his family.
I used to tell my kids they have to accept somebody like Parker. They will be going out there with other people and they might come across somebody like Parker. So before getting out there, they have to accept their uncle.
When he came here to work with HIV children, they were not of awareness that some of these problems that HIV children have, and they invite families, then we all go and attend, so the kids were sensitized during those times, so then they tend to educate others that people are different the way they are, to accept them. Some years down the line, we find out that one of our child is gay, and I guess the same acceptance that we have when I found out that Parker was like this.
If we are to address the sexual and reproductive health and rights of a country's citizens, I believe that while the families such as Parker's we've just seen, the nation-state, churches and communities are important, emphasis also must be placed on the cultures of healthcare practices. Just last week, I sat with a group of leading health professionals working in the field of two of the largest faith-based organisations. I, a Caucasian woman, was asked to train them on sexual health in their country. The irony didn't slip by me. No slides, no handouts, no notes. We just sat together and we shared stories. Many were at my own expense. I used my own stories of negotiating cultural beliefs and practices with my PNG husband and our children as opportunities to talk and reflect safely and openly. As we shared stories of our experiences, the stories went deeper and revealed more of the complexity of providing sexual and reproductive health and the ability of these healthcare workers in a faith-based organisation to respond. Many reflected on their own lives, their own clans, their own villages, and they also reflected on those of their clients. They also became more reflective and critical of their own cultures and what can and cannot be talked about. In the discussions that ensued, the healthcare workers started to challenge themselves and, most importantly, each other. They raised issues and talked about approaches they'd never had the opportunity to think, feel, or talk about before. They came to a space where they talked about wanting to transform the socio-cultural practices of their workplaces and how they talk to those who access their services. They also wanted to provide more services. They wanted to include testing for STIs rather than syndromic management. But more than that, they wanted to talk about other things. They wanted to talk about sexual pleasure, sex during pregnancy, impotence, and much more than diseases. They wanted to be more receptive, more open, and create a place, as one woman said, "I want us to be more than a place where people bring me their diseased organs. I want to talk about other things like the bedroom and positive sexuality." In short, they wanted to transform their workplace culture. PNG is a complex country where the ideas of culture can be used to restrict or transform sexual and reproductive health practices and attitudes. And it's all too easy to reinforce the negative and restrictive aspects in which it does this. We need to foster working in ways that support socio-cultural transformations, not only at the level of the state, the church, or indeed families like Parker's. We need to work to create enabling cultures of health services and practices, irrespective of whether they are run by the state, churches, or government. If we do this, I'm sure we'll be taking the right steps forward to ensure that no one is left behind.
Thank you very much.